Vice-Chancellor, the leadership of the university, our Dean, current and past staff of the Department of Medicine and University, distinguished guests, students, ladies and gentlemen, good evening, and a warm welcome to the fourth Dr. Stuart John Saunders Lecture. This lecture is co-hosted by the Department of Medicine and the VC's office. A special welcome to Professor Saunders' son, John, and his wife, Elizabeth, as well as members of the Saunders family in attendance online. Your presence here is sincerely appreciated. I wish to extend a special welcome to Emeritus Professor Solly Benatar, who succeeded Professor Saunders as the fifth chair of medicine and was also the second guest speaker of the series in 2029. A final special welcome goes to Professor Ntobeko Ntusi, the eighth chair of medicine, and tonight's guest speaker. Both these gentlemen are living proof of the legacy, the extraordinary legacy of Professor Saunders. Tonight's proceedings will be as follows. After my remarks, I will ask my co-host and our Vice-Chancellor, Professor Musa Mushabela, to speak on the history of the lecture and its significance for the university. Thereafter, the Dean of the Faculty of Health Sciences, Professor Lionel Green-Thompson, will step forward to introduce our speaker. When Professor Ntusi has concluded his address, Professor Mark Blockman, a valued leader in our department from the Division of Pharmacology, will thank the speaker. What can one say about Professor Stuart Saunders? He was a colossal giant in the field of medicine. As an internationally acclaimed clinician scientist, visionary, talented administrator, educator, mentor, philanthropist, activist, and role model. How does one begin to summarize his extraordinary contributions in a few minutes? Well, one really can't. But allow me to highlight a few aspects of his career. He was a pioneering liver researcher and a transformative leader whose tenure at UCT spanned some of the most challenging years of our history. Renowned for his intellectual rigor, integrity, and unwavering commitment to social justice, he exemplified courage and vision. It is well known that he championed racial integration at UCT, opening residences to all students and significantly increasing Black student enrollment. But he went beyond that. In recognizing the systemic barriers faced by these students, he also implemented academic development programs and provided opportunity to ensure that these students succeed in the system. Additional examples of his principled leadership are his opposing of the quota bill. So this was a bill which sought to enforce racial quotas at universities. And he also led successful legal battles against the government, against government-imposed conditions on university subsidies, as well as segregated medical training. Beyond UCT, after he had been retired, Professor Saunders played a pivotal role in securing international funding for South African universities, establishing the UCT Fund and Trust, and advocating for the broader higher education sector. Recognized with numerous honorary doctorates and the Order of the Baobab, Professor Saunders' legacy endures, not only through his contributions to medicine and higher education, but also through his embodiment of fairness, compassion, and the transformative power of leadership that was deeply rooted in his values. I have enumerated many or some of the highlights of his illustrious career. But for me, what is most remarkable and set him apart was his dedication to his patients. Despite reaching the dizzy heights of a truly successful academic career, he did not lose sight of his commitment to the humble practice of medicine. Even as VC, he led a medical team, seeing patients every Friday here in the All Main building, and remained a fixture at the liver clinic, the very one that he co-founded many years before, attending every clinic on Tuesday without fail. This is where I first met him. I always remember with a deep sense of gratitude how the late Professor Bongani Mayosi sent me to him for a meeting when I was confused about my next step. He welcomed me into his home, where we had a lovely chat on the stoop overlooking the city, drinking a cup of tea. What I thought would be a meeting turned out to be a deeply meaningful conversation, one that clarified my path forward and had a profound impact on my life and career. This exemplifies the essence of his mentorship. It was personal, thoughtful, transformative, and I feel humbled to be able to give a personal account of that. In closing, the annual Dr. Stuart Saunders Lecture that was launched in 2018 stands as a testament to his enduring impact, honoring the values of inclusivity, excellence, and courage, all the values that he espoused throughout his remarkable life. Thank you.
Ladies and gentlemen, good evening. Guests, students, staff, friends, family, colleagues of the University of Cape Town. Welcome to this special lecture that we are receiving this evening. It is for me a privilege to welcome all of you to the 2025 Dr. Stuart Saunders Memorial Lecture. It is one of the significant occasions in our calendar as UCT. This evening, we gather to honor a remarkable legacy that I also so often refer to in my talks, but we get to reflect on the transformative contributions of Dr. Stuart John Saunders, an esteemed alumnus of UCT, a visionary leader, a vice-chancellor of the university, an icon in medicine and in higher education. The theme this year is Reconceptualizing Global Health and Medicine, a time for courage and ethical leadership. This, of course, embodies the values and principles that defined Dr. Stuart Saunders' life and career. Since its introduction in May 2018 as a tribute to Dr. Saunders, who served as the Vice-Chancellor of this great institution for 15 whole years, from 1981 to 1996. This initiative is made possible through the generosity and vision of his late wife, Anita Johanna Saunders, and it seeks to celebrate his unwavering commitment to excellence, integrity, and service. Through the series, we aim to perpetuate the ideals that Dr. Saunders upheld and to inspire future generations to embrace courage and ethical scholarship in addressing the challenges of our time. Dr. Saunders' journey with UCT began when he studied and graduated with an MB-CHB degree in 1953. His pursuit of knowledge took him to the Royal Postgraduate Medical School in the United Kingdom and Harvard University in the United States. He returned to UCT to complete a Doctor of Medicine degree in 1965. Testament to his enduring connection to this very institution. Over the course of his illustrious career, he received numerous accolades, including the Order of Baobab in 2002, a prestigious national honor recognizing his distinguished service to the country, South Africa. He was also awarded 7 honorary degrees by the universities of Aberdeen, Cape Town, Princeton, Rhodes, Sheffield, Toronto, and Wits. Beyond his academic and professional achievements, Dr. Saunders' leadership extended into various roles that strengthened UCT's foundations. He served as a board member of the UCT Trust in the United Kingdom, president of UCT Heritage Society, president of UCT Convocation, and trustee of the Claude Lyon Foundation. His dedication to this university was profound and enduring. Tonight, we also get to recognize the Saunders family for your unwavering support of UCT and this lecture series. To John Saunders, your father's legacy lives on not only through this lecture. It continues to enrich our community and challenge us to aspire for higher ideals, but also through the impact he made during his time at the helm of this institution. To John's wife, Elizabeth, and the entire Saunders family, please accept our heartfelt gratitude for your family's invaluable contributions to UCT. I also wish to take this moment to acknowledge and thank those whose relationships with Dr. Saunders and his family have added to the richness of this occasion. To mention some of them, this include Dr. Charles Kennan, friend and former student of Dr. Saunders, Heiko Alfeld, friend of the family, Professor Soli Benata, friend of the family and former close colleague of Dr. Saunders in the Faculty of Health Sciences, as well as his wife, Evie. Emeritus Professor Wieland Givers, former Deputy Vice Chancellor of UCT. There are many colleagues that are here. We acknowledge and thank all of you. This year's lecture series holds a special place in our hearts as it forms part of the broader UCT summer school program. Its inclusion reflects the enduring appeal of the Dr. Saunders legacy to our alumni and the wider UCT community. It is an opportunity to reach even more individuals who share a commitment to advancing knowledge and fostering meaningful change. As Dr. Stuart Saunders would say, leadership is not about personal ambition, but about inspiring others to achieve the extraordinary and make a lasting impact. Let these words guide us as we reflect on his remarkable life and the indelible mark he left on UCT and the world. Let tonight's lecture challenge us to reconceptualize global health and medicine and to seek innovative, inclusive, and ethical solutions to the pressing issues of our time. Thank you for joining us. May you find inspiration and insight in Professor Ntobeko Ntusi's speech and the discussions that will follow. And I also want to acknowledge the presence of your family in the room today. Thank you very much.
It's a real honor, Ntobeko, to invite you back into a place I think you regard very much as yours. And that's really a significant part of our story. So Stuart Saunders graduated in the class of 1953. And I wondered how early I had heard Stuart Saunders' name in my own story. But it came up every now and again while I was a student, but also as a child growing up, because my father had graduated in that class, the class of 1953. And while their experience of their student days was no doubt in that time marked by our inequities and the prejudice that prevailed at that time, I've no doubt that it must have been part of that experience that already formed Stuart Saunders into the person he was going to be. And so in the 1980s, when I was an undergraduate student and an activist, we came to recognize that Stuart Saunders was a vice-chancellor, first among equals, because in that period, those vice-chancellors needed to speak with a clarity of purpose and a sense of the national imperatives of that day. And so I come very honored at this time to reflect on this lecture, but really in the spirit of introducing Ntobeko. And so I want to say Ntobeko currently is the President and Chief Executive Officer of the South African Medical Research Council, having left the Department of Medicine only partially because he remains a full professor in the department. So he shifted offices, but I think he left some of his brains here to continue the work that is ongoing. I think we're all very aware of the list of qualifications that Ntobeko has, but I was quite struck that the most recent is 2022, a certificate in executive leadership from the Cape Higher Education Consortium. Now, it's useful to reflect on CHEC itself because CHEC is the only one of these consortiums, the one in the Western Cape, that has actually survived since the change. It was something that was conceived at that time. And so they continue to make a significant contribution. I think reading a CV is also a little bit boring, and so I thought I would try and craft this introduction in the way that I've come to know Ntobeko. But as I looked, and one can't get through all of his 350 plus publications in a couple of days, but I picked up one where there was a perspectives profile in the Lancet written by Udani Samarasekera. The title of it is Ntobeko Ntusi, Valuing a Culture of Inclusivity and Reciprocity. And I suppose those are some of the features I want to introduce, to just mention in terms of this introduction. I want to speak about leadership, I want to speak about vision, and I want to speak about advocacy. Because in the way the talk is crafted this evening, it would suggest that we're going to have some challenging discourse this evening about where we are and where we should be going. Ntobeko speaks in that article of bias, and speaking about, and you can see the dumbfounded faces, because it's not something they do consciously, but these biases are so inbuilt even at that young age. And he was talking about the bias that ensues when you call a patient an HIV sufferer, when it has no bearing on what the patient is presenting with. Val, in that article, speaks about his major contributions in defining clinical features, outcomes, and genetic underpinnings of cardiomyopathy in Africa, describing mechanisms and phenotypes of HIV-associated cardiovascular disease. But perhaps this is the best part of the introduction: extraordinary physician, scientist, and humanist. And in reflecting on the CV, one can see that emerge in so many of the things that he speaks of in his CV. He speaks about this as when he lists one of his attributes, he speaks about this advocacy, championing cardiovascular and non-communicable diseases, treatment access, affordability, and equity. But linked to that, a lasting memory for me about this advocacy was Ntobeko standing on the pavement outside Reconceptualising just after the protest, when the naysayers would advance themselves upon the hospital to say, stop this, it's not good. But he was able to come onto national TV that evening and speak power to the naysayers of that time. And so that advocacy for me is something that resonates in the way that Ntobeko presents himself in our space. He spoke in that article of the fact that at UCT, how we build alliances and share power with historically marginalized and minoritized physicians and other stakeholders as an essential part of the leadership and inclusivity that he espoused. But he went on to say, and this is a thing that I think the Department of Medicine in all of its generations have continued to do, is this idea. We looked at how we find opportunities for equitable endeavors whenever we introduce new innovations into research or clinical spaces, based essentially on the impact on access, affordability, and what different segments of our society think. If one looks again at Ntobeko's CV, you see that is manifest in the multiple relationships that he's built, both locally in the city, and beyond our city nationally, continentally. Ntobeko's name is easily recognized in the discourse across many fronts, not only in the medical field, and of course his significant global presence. In his list of awards, so just coming back to the publications and metrics for his science, Ntobeko has more than 350 peer-reviewed manuscripts, 15 book chapters, and 300 peer-reviewed conference proceedings, an H-index of 45, but citations that number way beyond 10,000. So it's not research for its own sake, it's research that people are recognizing to be making a contribution to science. He's supervised a number of master's and doctoral students. There are a series of awards and achievements that are listed in his CV, the most recent of which, Ntobeko, I want to note particularly, is the Fellowship of the World Academy of Science. And I was quite struck that in my congratulatory message to him that evening, when I read the news for the first time, he said, "This is the work of the teams that I work with." And that's for me, a real tribute to the nature of the leadership that we see in Ntobeko, this notion of your first response is to recognize those around you, and I think that's not insignificant. But Ntobeko has also been a winner of the South African Medical Research Council Gold Medal. He's a UCT College of Fellows member. He's got fellowships from the Royal College of Physicians and the Royal Society of South Africa. But perhaps the one that I was particularly intrigued by, because it is something that was clearly in his genes. He won the Harvard, in 1995, when he was at school in the United States, he won the Haverford College Archibald McIntosh Award for the best scholastic and athletic excellence. And those of you who've spent any amount of time with Ntobeko knows that the intellect ranks right alongside the physical capacity for endurance. And so it's quite an interesting award to see that started the whole story off. But I want to close perhaps with a remark that he made in his own piece in an editorial in March 2020 for South African Heart. He was speaking about cardiovascular disease and global health, a perspective from the global south. The thing that he crafted about global health in that presentation was about this idea that global health is important in cardiology, as international collaboration in research and programmatic approaches is increasingly the norm. But he goes on to speak about training in that piece where he says, however, such opportunities for training and fellowship in global cardiovascular health have largely benefited students from high-income countries, as relatively few students from low middle-income countries are able to afford and take up the opportunities for exchange. And I think those remarks continue to echo in the discourse around global health, because even the nature of training and the expertise currently being developed in global health is located in the global north. And I suspect that may well be some of the comments he makes this evening as I welcome Ntobeko to deliver his lecture this evening, Reconceptualizing Global Health and Medicine, a Time for Courage and Ethical Leadership. Welcome, Ntobeko.
No country can achieve sustainable development without also building its strength in science and technology. This implies inexorably a need to reinforce science education, to train a critical mass of researchers, to create research infrastructures facilitating an environment in which innovation can thrive, and more. The task is enormous. It requires simultaneously government policies, financial backing, strategies, and well-defined priorities to seed the development of science, technology, and innovation. Further, universities and scientific centers must fund research and development, create inclusive avenues to ensure that the talent pool incorporates women and other marginalized groups, and establish robust educational policies that can stand the test of time. And it must be done in countries where resources are scarce, in which fundamental needs such as food, water, war, famine, government corruption, and education compete with research and development for funding. Therefore, in all of this, the voice of scientists, clinicians, and indeed all activists must be heard as we define our priorities in the face of urgent challenges. This endeavor is even more important and acute in the Global South. In today's lecture, my hypothesis is that the skewed structures and asymmetric financial, epistemic, and power dynamics of global health in its current formation are both unsustainable and untenable. Instead of its promise of equity and social justice, global health has been characterized by a demise of the global, as it has increasingly been the pursuit of individuals in the global north. All the practitioners of global health are, after all, mostly based in the global north. Scientists from the global south rarely describe their work as global health. Features of patriarchy, racism, white supremacy, saviorism, neocolonialism, foreign gaze, and power asymmetries between high-income and low and middle-income countries, as well as the increasing lack of diversity, equity, and inclusion, are some of the dire challenges that lie at the heart of what has gone terribly wrong with global health. Therefore, reimagining global health requires that we address these intersecting systems of privilege and supremacy that continue to limit our ability to achieve equity and justice. Inequities are not only about the needs and concerns of the disadvantaged, but also about the systems that create disadvantage. To borrow from the words of Sei Abimbola, Maduka Pai, and colleagues, privilege is complex and relational. The social structures that create disadvantage are exactly the same ones that create advantage from which others benefit. As I do with all of my talks, I would like to start with this history statement from the South African Medical Research Council, acknowledging our catastrophic and persisting legacy of colonialism and apartheid, which has resulted in many educational and health inequities, and to affirm our commitment to the continued promotion of health justice, dignity, and equity. Please note my research funding disclosures, none of which have any relevance for tonight's lecture. I have no conflicts of interest to declare. So good evening, dear friends and colleagues. It is with great humility and honor that I stand in front of you to deliver the 2025 Dr. Stuart John Saunders Lecture. I'm grateful to Professor Mashiko Setsedi for the invitation, and I'm particularly delighted to be able to deliver my remarks this evening in front of John and Elizabeth. The Vice-Chancellor of the University of Cape Town, Professor Musa Moshabela, the Dean of the Faculty of Health Sciences, Professor Lionel Green-Thompson, the Chair and Head of the Department of Medicine, Professor Mashiko Setsedi, Emeritus Professor Willem Gievers, previous Vice-Chancellor and Founding Director of the IDM, as well as Emeritus Professor Solly Benneter, previous Chair of Medicine, the family of the late Professor Stuart Saunders, in attendance online, esteemed guests, and my dear colleagues. It is with a heavy heart that I greet you. Several months back, when I proposed this title for my lecture, I could not have predicted how ominous it would be. For in the single week since the new US administration took office, a series of harmful and retrogressive policies that restrict US international development assistance to organizations providing global health have been enacted, threatening to undermine the laudable gains in global health achieved over the last 4 decades. These events represent a significant setback for global health, for human rights, for health justice, and particularly for vulnerable communities world over who already face systemic barriers to accessing basic health. The receding global solidarity and collaboration alongside the rise in nationalism and polarization spells a dubious future for global health. The events of the last week have been most unsettling, and in a more equal and equitable society, no single country should ever have so much influence on the health of so many outside of its borders. I knew Stuart over many years, and our relationship evolved as we both grew older. I first met him as a young medical student. He was an inspiring teacher, a giant in our field, respected by all, with an encyclopedic knowledge of clinical medicine and with the most wonderful bedside manner. Most recently, I knew Stuart as a mentor and a friend. He is unforgettable, as was his love for this department and university. He was a man of principle with strong moral conviction. He left an enduring impression as a most courageous and ethical leader. As we celebrate his legacy today, I have thought long about the lessons we could learn from his leadership as we reimagine global health. Stuart was viciously opposed to injustice in all its forms. As the chair of medicine, he opposed the segregated training of registrars. And as vice chancellor, he opposed segregated residences at the University of Cape Town. His unwavering commitment to academic freedom was admirable. He established the UCT Legacy Society and initiated fundraising for the protection of academic freedom at the University of Cape Town. All who knew him should be proud of the rich legacy he leaves behind. I wish to pay particular tribute to Anita Saunders on her vision of establishing this lecture so that future generations may continue to benefit from the example and teachings of Stuart. Over the next 20 to 25 minutes, I plan to cover 3 areas. Firstly, a discussion of what we mean by global health. Second, to review the current state of global health. And finally, to end by proposing what a revised concept of global health may look like. Debate around a common definition of global health has seen extensive scholarly interest within the last 3 decades. In 2009, a widely circulated paper by Jeff Copeland and colleagues aimed to establish a common definition of global health as distinct from its derivations in both public health and international health. They rooted the definition of public health in the mid-19th century social reform movements of Europe and America, the growth of biological and medical knowledge, and the discipline's emphasis on population-level health management. Similarly, they trace the evolution of international health back to its colonial roots in hygiene and tropical medicine through to the mid-20th century, with its geographic focus on low and middle-income countries. Global health, on the other hand, they argued, would require a distinctive definition of its own, to be more than just a mere rephrasing of public health or a politically correct updating of international health. Their intervention built on prior research, noting confusion and overlap among the three terms, and thus a need to carefully articulate the important difference between them. In articulating the difference between global health, public health, and international health, 4 sub-themes emerged, and these include: 1, the recognition that global health is a multiplex approach to worldwide health improvement taught and pursued at research institutions world over. 2, that global health is an ethically oriented initiative that is guided by justice principles. And 3, that global health is a mode of governance that yields influence through problem identification, political decision-making, as well as the allocation and exchange of resources, often across borders. And finally, that global health is a vague yet versatile concept with multiple meanings, historical antecedents, and an emergent future. Writing in the Lancet Commission on advancing global health and HIV care in the era of the Sustainable Development Goals, my colleagues and I wrote, the SDGs sharply elevate global health and its development aspirations, contemplating a world that is far more prosperous, more secure, more healthy, and more equitable, where human rights and dignity are universally respected, and where human development unfolds in a manner that preserves the natural environment. Yet, the 3 years that have passed since the SDGs were agreed have dimmed prospects of achieving many of these visionary aims. And by contrast with the international solidarity, the shared commitment and increased investment that characterized the era of the Millennium Development Goals, much of the world has, since 2015, turned inward and towards authoritarianism, repression, a diminished role for civil society, a policy of austerity for public investments, particularly in health, and a suspicion of international collaboration. As a result of civil conflicts that have yet to elicit an appropriate response, more people than ever have been forced from their homes and countries. And at a time when the fruits of scientific advances are so evident, denial in many quarters of the role of humankind in the degradation of our environment threatens the very health and well-being of our planet and civilizations, end quote. And sadly, these words feel even more truer today than they did 9 years ago. Global health is inherently inequitable and is failing dismally on all measures of equity. The rise of nationalism, right-wing politics, and the erosion of democracy world over worsen the existing global health inequities. Many have argued that these power asymmetries need to shift from inequity to allyship. Global health continues to be a field where global North actors see themselves as experts and leaders. Although the decolonizing global health movement has exposed some of the deep inequities inherent within the architecture of global health, this movement, prone to elite capture, faces several institutional barriers that prevent meaningful shifts in power. The lack of allyship in global health has recently manifested itself as vaccine apartheid, led by global North countries who hoarded vaccines for COVID-19, Mpox, and Ebola. I would argue that the current posturing by the Trump administration is another flagrant example of absent allyship. While diversity, equity, and inclusion are clearly on the decline in global health, all efforts to correct this are increasingly seen as wokeism and reverse racism. Therefore, if we are to move forward, there needs to be a concerted effort to support Global South leadership of global health. Importantly, Global North funders, donors, and philanthropic organizations wield enormous influence on all aspects of global health. They are the ones who decide who leads organizations, who receives funding, and what global health interventions are prioritized. And most global North universities and international non-governmental organizations are unwilling to discuss the disproportionate influence of wealthy donors because they fear jeopardizing their own funding. So there have been growing calls to decolonize global health. This process is obviously just only the beginning. But what would success look like? And would global health survive its decolonization? To quote from this paper, there is a question that fills us with imagination. It's a question that makes us reflect on what Martin Luther King saw when he said in 1968, in the last speech he gave before he was assassinated, that I've been to the mountaintop and I've seen the promised land. If what he saw was an equal, inclusive, and diverse world without a hint of supremacy, then that world is clearly still elusive. Similarly, an equal, inclusive, just, and diverse global health architecture without a hint of supremacy is not global health as we know it today, end quote. To decolonize global health is to remove all forms of supremacy within all spaces of global health practice, within countries and between countries and at the global level. Supremacy, as you may think, is not restricted to white supremacy or male domination. It concerns what happens not only between people from high and low income countries, but also what happens between groups and individuals within high income countries and within low and middle income countries. Supremacy is there glaringly in how global health organizations operate, who runs them, where they are located, who holds the purse strings, and who sets the agenda, and whose views, histories, and knowledge are taken seriously. Supremacy is seen in persisting disregard for local and indigenous knowledge, pretense of knowledge, refusal to learn from places and people too often deemed inferior, and a failure to see that there are many ways of being and doing. Supremacy is also there in persisting colonial and imperialist attitudes, in stark and disguised racism, white supremacy, saviorism, and displays of class, caste, religious, and ethnic superiority, in the acquiescing tolerance for extractive capitalism, helicopter science, patriarchy, and more. Ultimately, though, the goal of global health should not to be the survival of its decolonization, but to rise up and live to the pressing demands of its mission. The reality of Martin Luther King Jr.'s dream of a just and equal world. Now that I've thoroughly depressed you about the current state of global health, how can we then reimagine it? To decide on the future priorities in global health, we need to understand the current trends that exist. So the first question we need to understand is what is the current state of global health? And you have to ask yourself a number of important questions. Firstly, which countries do global health dollars mostly go to? And that's the global north. Who is publishing in global health journals? It's also scientists from the global north. Who edits these journals? It's also scientists from the global north. And where are global health degrees awarded? In universities in the global north. And where are these global health conferences held? Also in cities in the global north. And who attends them? Scientists from the global north, because scientists from the global south often cannot get visas to attend such conferences. And who funds scholarship in global health? Funders from the global north. And so you might ask yourself, what are some of the policies of global north countries that sustain the status quo? Vaccine apartheid, visa apartheid, increasing nationalism and right-wing politics, but also the cost of global health degrees. So the average cost of a master's in global health is about $70,000 US, and a doctorate in global health is far more expensive, which are clearly unaffordable for scholars from the global south. But also the way the systems of incentivization work at universities that favor qualities that accrue to scientists from the global north in such partnerships. So in reconceptualizing global health, we need to understand what some of the trends are that are currently on the go. There have clearly been a number of important advances, including increasing scientific knowledge, increasing momentum of the project to decolonize global health, the globalization of clinical trials, and a number of important advances. But these need to be considered alongside some of the important challenges, including widening global disparities, a crisis of governance in healthcare, climate change and health, worsening mental health, receding trust in governments and in science, and of course, epidemics of both antimicrobial resistance and non-communicable diseases. The pursuit of equity, social justice, and health justice must be at the center of all global health efforts. And I like the slide from the World Economic Forum stating a vision for healthcare of the future with equity thrust in the center, with 4 key goals of equitable access, healthcare system transformation to have greater equity, technology and innovation that enables equity, and of course, environmental sustainability. Those of us who have a loud voice in global health should collectively affirm our ownership of the field. We need to claim the space in global health that belongs to us and is proportional to the size of our populations, the size of our knowledge, and the size of our problems. We need to convert the opportunities we receive into opportunities we give, to weave networks of solidarity with peers, and build collaborations across the global South, without necessarily decreasing established North-South partnerships. Currently, in many global South settings, particularly in Africa, universities and research institutes are more likely to have global North than in-country or in-continent collaborators, which are essential for solidarity and learning across settings. And even within Southern networks, there is a need to engage women, to engage frontline workers, and people with lived experience, since they are often invisible in national consultations and committees. And thinking about how we may cultivate a global South with agency, I like this quote from this paper, which reads that claiming space requires confidence. It requires that we believe we can, and we already hold and have the capacity to produce knowledge that may be transformative. However, our confidence in the potential of our ideas and actions is weakened by the weight of asymmetry that comes with being on the receiving end of sometimes valuable support, knowledge, and interventions. Often, we just assume we are not good enough or trained enough, and someone with more experience in a better institute in the global North will do something better, without considering the migration of skills from the global South. Sometimes this belief is foisted on us by colleagues in or funding from the global North. How else can we reimagine global health? I wish to argue that a key change that needs to occur is the ability to localize funding decisions. Much too often, international donors and funding organizations who come as saviors prefer to fund projects that address their own interests on their own terms. This is in turn something that leads to a waste of resources, lack of local buy-in, and loss of local research interest, and a lack of trust between grantees and donors. Even when research or implementation work is focused entirely on low and middle income countries, much of donor funds are given to agencies and institutions in high income countries, and therefore these countries hold the purse strings and control the agenda. Much of global health is conducted through universities and similar research entities. It's a major problem that academics in the global North, and to my sadness, increasingly in the global South, are incentivized to focus primarily on personal development. For example, achieving tenure, receiving awards, publications, or grants, often at the expense of real impact. Universities and academic institutes involved in global health need to be held accountable for creating structures and processes that incentivize academics to be better allies. and be responsive to decision makers on the ground, engaging with organic local processes and indigenous knowledge, and engaging with local partners and leaders of the process of knowledge production and its use. Importantly, low and middle income country governments and institutions must invest more in their own healthcare delivery, in their own research, and in their own training to reduce their dependency on high-income countries. Situations, as we have witnessed this week, where countries like America can weaponize programmatic global health funding due to their substantial influence, resulting in instantaneous loss of millions of livelihoods. This should not exist. Therefore, building quality research and training institutions in low and middle income countries is critical to reduce reliance on high-income countries and to improve the overall quality, depth, and impact of scientific training, research, and its conduct. The current global health landscape is heavily centralized and homogeneous. Global health remains too much centered on individuals and agencies in high-income countries. Most renowned global health leaders remain white, male, able-bodied, and often with a degree from an elite high-income country, university, and often lead organizations headquartered in the global north with ground operations governed from a distance in the global south. Finally, decolonizing global health is of great interest, but it's very difficult as systems are entrenched. We need you, all scientists, clinicians, and concerned citizens, to continually question the skewed ways in which global health is being studied, taught, funded, researched, driven, designed, and implemented. The accountability and shaping of power dynamics are at the heart of my proposals for change. These are not easy, even for people and organizations that are avowedly well-intentioned and equity-focused. But good intentions are not enough. So in closing, I also wish to argue that we need greater moral courage. Moral courage is the ability to stand up for and practice what one considers ethical, moral behavior, often when faced with a dilemma, even if it means going against countervailing pressures to do otherwise. Moral courage is found at the nexus of principles, danger or risk, as well as endurance. Like Stuart Saunders did in his day, we are all called to have moral courage in contribution to the global agenda to transform global health. I thank you for your attention.
Professor Saunders and Ntusi's family, Professor Moshabela, Professor Green-Thompson, Professor Sechedi, Head of Medicine, ladies and gentlemen and colleagues, it's a privilege to thank Ntobeko, our wonderful colleague and friend, for this excellent talk. I'm convinced, and I worked with Professor Saunders, that he would have celebrated this talk with us this evening and the topic. Ntobeko, the way you broke down such a complex and critical topic with clarity and compassion is truly inspiring. Your call for courage in challenging entrenched inequities and for ethical scholarship in shaping global health practices resonates profoundly. It is a timely and necessary reminder of the responsibility we all share in advancing a more just and compassionate approach to health and medicine. You not only highlighted the ethical complexities we face, but also challenge us to approach them with courage, compassion, and a commitment to justice. This talk is important for our institution because addressing injustice begins with awareness, dialogue, and a willingness to confront often uncomfortable truths. And Ntobeko, your work inspires us to push boundaries and challenge the systems that perpetuate inequity. Your words remind us of the transformative power of ethical leadership in shaping a better future. I also want to thank all of you in the audience and online, because by being here, you've shown a commitment to understanding and addressing the systemic barriers that affect so many lives. Change doesn't happen overnight, but it does start with each of us making a conscious effort to listen, learn, and act. Let's leave this evening not only with a deep understanding of global research injustice, but with a renewed determination to dismantle it and build a future grounded in equity and justice. Once again, thank you, Ntobeko, for an outstanding and impactful talk. Thank you very much. Please accept this on our behalf.
I'm not sure that there's anything left to say, except perhaps to thank all those that have been involved in the organization and execution of this lecture. Specifically, I'd like to thank the VC and his office, family members and friends of the Saunders family, UCT entities, so here I'm talking about the summer school, the Department of Medicine, CMD, Grooteskier Hospital, and the AV team who have helped to make this event a success. I would be remiss if I did not single out Claire Jeffrey. She's sitting over there. She has worked tirelessly over months to organize this event. But most importantly, I'd love to thank each and every one of you who's here in person and online, who has taken the time, who has made the effort to join us, to support us, and to share in this wonderful celebration today, in the first hybrid offering of this series. Thank you so much, ladies and gentlemen, and good night.